Pituitary Disorders and why Ali Jama asked. Professor and Consultant. Medicine and Endocrinology. King Saud University. Objectives: Basic Embryology, Anatomy and Physiology. Non-functional pituitary tumors mass effect. Prolactin secreting cell disorder, prolactinoma. Growth hormone secreting cell disorders. AGT secreting cell disorders. TSH secreting disorders. Gonadotropin secreting cell disorder. Pituitary development. Anterior pituitary is recognizable by 4/5 WK of gestation. Full maturation by 20th WK. Diaphragm ocella is formed by a reflection of dermata preventing CSF from entering the cellulosica by this diaphragm. Pituitary development. Anterior pituitary developed from Rathke's pouch, ectodermal invagination of oropharynx and migrate to join neurohypophysis. Posterior pituitary from neural cells as an outpouching from the floor of third ventricle. Pituitary stalk in midline joins the pituitary gland with hypothalamus that is below third ventricle. Pituitary anatomy lies at the base of the skull as cellulosica. Roof is formed by diaphragm ocella. Floor by the roof of sphenoid sinus. Diaphragm ocella is formed by a reflection of dermata preventing CSF from entering the cellulosica by this diaphragm. Pituitary anatomy. Pituitary anatomy. Pituitary stalk and its blood vessels pass through the diaphragm. Lateral wall bicavernous sinus containing 3, 4, Vi, V1, V2 cranial nerves and internal carotid artery with sympathetic fibers, both adjacent to temporal lobes. Pituitary gland measures 15 by 10 by 6 mm, weighs 500 mg but about 1 gram in women. Height is 5 to 7 mm and 10 mm lateral dimension, height is 10. Superior, middle supply ant, pituitary, inferior supply stalk and post-pituitary artery. Pituitary anatomy. Pituitary anatomy. Optic chiasm lies 10 mm above the gland and anterior to the stalk. Vascular and neural connections between the hypothalamus and pituitary. Blood supply, superior, middle, inferior hypophyseal arteries, internal carotid artery, running in median eminence from hypothalamus. Venous drainage. To superior and inferior petrosal synthesis to jugular vein. Pituitary anatomy. Optic chiasm lies 10 mm above the gland and anterior to the stalk. Pituitary hormones. Posterior lobe. Anterior lobe. Cell types of adenohypophysis. 1. Acidophils, stain with acidic dyes. 2. Basophils, stain with basic dyes. 3. Chromophobes, do not stain with either stain. Acidophils. Somatrophs, secrete growth hormone, GH. Mammotrophs, secrete prolactin, PRL. Basophils. Thyrotrophs, secrete thyroid-stimulating hormone, TSH. Gonadotrophs, secrete luteinizing, LH, hormone and follicle-stimulating hormone, FSH. Chromophobes, secrete adenocorticotrophic hormone, ACTH. Hypothalamic stimulatory hormones. Corticotropin-releasing hormone. Adrenocorticotropic hormone, ACTH, 20% of cells in anterior pituitary. Melanocyte stim hormone POMC product. Endorphins, also products of POMC gene. Growth hormone releasing hormone. Growth hormone, GH, represent 50% of cells in anterior pituitary. Gonadotropin releasing hormone. Luteinizing hormone and follicle stimulating hormone. Gonadotrophs represent about 15% of anterior pituitary cells. Thyrotropin releasing hormone. thyroid-stimulating hormone, TSH. Thyrotropes represent about 5% of anterior pituitary cells. Prolactin-releasing factors, serotonin, acetylcholine, opiates, and estrogens. Prolactin, lactotrophs represent 10 to 30% of anterior pituitary cells, releasing hormones of hypothalamus. Summary: releasing hormones of hypothalamus. CRH, TRH, GnRH, GHRH, FSH, LH, ACTH, TSH, GH. Stimulating. HAP. Adrenal. Cortex. Thyroid. Gland. Gonads. Generalized. Hypothalamic inhibitory hormones. Somatostatin. Inhibits the release of growth hormone. Prolactin inhibiting factors, includes dopamine. Major prolactin control is inhibitory. Cell masses causes, benign tumors, metastatic cysts. Pituitary adenoma, most common cell mass. Lung. Craniopharyngioma. Breast. Meningiomas. Cysts. Pituitary hyperplasia. Rathke's cleft. Lactotroph hyperplasia, during pregnancy. Arachnoid. Thyrotroph and gonadotroph hyperplasia. Dermoid. Somatotroph hyperplasia due to ectopic GHRH. Pituitary abscess. Malignant tumors. Lymphocytic hypophysitis. Primary. Carotid arteriovenous fistula. Germ cell tumor, ectopic penioloma. Sarcoma. Chordoma. Pituitary carcinoma, rare, cell masses causes, neurologic symptoms, most common. Visual impairment. Headache. Other, including diplopia, seizures, and CSF rhinorrhea. Incidental finding. When an imaging procedure is performed because of an unrelated symptom. Hypopituitarism. Biochemical evidence, most common. Clinical symptoms, less common, but include oligomenorrhea or amenorrhea in women, decreased libido and or erectile dysfunction in men. Left side microadenoma post-contract. Evaluation of pituitary mass. Pituitary incidentaloma, 1.5–31% in autopsy, prevalence. 10% by MRI, most of them less than 1 cm. Guanine nucleotide stimulatory protein gene found in 40% of somatotroph adenoma/inactivation mutation in tumor suppressing gene in men 1. Assessment of pituitary function. Baseline, TSH, FT4, FT3, LH, FSH, prolactin, GH, IGF-1, testosterone, estradiol. MRI brain. Neurothalamic evaluation of visual field. Evaluation of pituitary lesion. Functional adenoma, hormonal secreting. Non-functional adenoma, primary and secondary endocrine diseases. Based on site of hormone defect, either increase or decrease secretion, endocrine disorders are classified as A. Primary disease, if defect is in the target gland from which hormone has originated. B. Secondary disease, if defect is in the anterior pituitary or hypothalamus. For example, primary hypothyroidism means decreased secretion of thyroid hormone from the thyroid gland. Secondary hypothyroidism means deficiency of anterior pituitary/hypothalamic hormone which stimulates production of thyroid hormone from the thyroid gland, defect not in the thyroid gland. Evaluation of pituitary lesion. Non-functional pituitary lesion. No signs and symptoms of hormonal hypersecretion. 25% of pituitary tumor. Needs evaluation, either micro or macroadenoma. Average age 50 to 55 years old, more in male. Non-functional pituitary adenoma. Presentation of NFPA as incidentaloma by imaging. Symptoms of mass effects: mechanical pressure, hypopituitarism, mechanism. Mass effect: tumor expansion, lateral compressing cavernous sinus causing cranial nerve palsy like double vision, stretching meninges causing headache, or pushing temporal lobe causing seizure, pushing optic chiasm or headache from apoplexy. Hypopituitarism from suprasellar mass pushing stalk and cutting portal blood supply and hypothalamus signal to pituitary. Approach to the patient with an incidental abnormality on MRI of the pituitary gland. Treatment of non-functional pituitary adenoma. Surgery. Recurrence rate 17% if gross removal, 40% with residual tumor. Predictors of recurrence: young male, cavernous sinus invasion, extent of suprasellar extension of residual tumor, duration of follow-up, marker, key 67. Observation. Adjunctive therapy. Radiation therapy. Dopamine agonist. Somatostatin analog. Tumor greater than 2 cm, visual field defect, optic chiasm compression or touching by tumor with no visual field defect, headache, suprasellar/parasellar tumor extension. Prolactin. Prolactin, PRL, is a single-chain polypeptide. Receptors resemble GH receptors. Structurally similar to GH. Increases during pregnancy and lactation. Predominant action on mammary gland. Also inhibits gonadotrophic hormone secretion, physiological actions of PRL. PRL is responsible for lactogenesis, initiation of lactation, and galactopoiesis, continuation of lactation. Stimulates milk production in the breasts. Stimulates breast development along with estrogen during pregnancy. Inhibits ovulation by decreasing secretion of LH and FSH. Factors affecting PRL secretion. Factors increasing PRL secretion. Estrogen, during pregnancy, stimulates lactotropes to secrete PRL. Breastfeeding, reflex increase. TRH. Dopamine antagonists. Factors inhibiting PRL secretion. Dopamine. Bromocriptine, dopamine agonist. Somatostatin. PRL, by negative feedback. Prolactinoma. Prolactinoma premenopausal women. Menstrual dysfunction, oligomenorrhea or amenorrhea 10 to 20%. Infertility, luteal phase abnormalities or anovulation. Galactorrhea. Postmenopausal women, already hypogonadal. It must be large enough to cause headaches or impaired vision. Incidental sellar mass by MRI. Men. Decreased libido and infertility. Erectile dysfunction. Gynecomastia and oligogalactorrhea. MJ Abstract Gynecol 1972, 113-14, N. Engel J. Med 1977, 296-589, Clindo 2000, 22-1085, Clinendocrinol 1976. Serum prolactin concentrations increase during pregnancy. Tyson al., MJ Abstract Gynecol 1972. List of drugs known to cause hyperprolactinemia and or galactorrhea. Typical antipsychotics. Gastrointestinal drugs. Chlorpromazine, clomipramine, fluphenazine, prochlorperazine, thioridazine. Cimetidine, Tagamet. Haloperidol, Haldol. Metoclopramide, Ritalin. Bimide, Arap. Antihypertensive agents. Atypical antipsychotics. Methyldopa, Aldamet. Risperidone, Risperdal. Risipine, Hydromox, Serpazole, others. Melindone, Mobin. Verapamil, Calin, Isoptin. Olanzapine, Zyprexa. Opiates. Antidepressant agents: codeine, clomipramine, anafranil, morphine, skipramine, norepinephrine. Growth hormone hyperfunctioning mass acromegaly. Pituitary tumor is mass effect growth hormone deficiency, short stature. Actions of growth hormone. Actions of GH are of two types: direct catabolic actions, indirect anabolic actions. What are somatomedins? IGF-1 polypeptides synthesized mainly in liver, also synthesized in kidneys, cartilage and skeletal muscles. The indirect actions are via the somatomedins. Actions of growth hormone: stimulation of growth of bones, cartilage and connective tissue, mediated mainly via somatomedin C, IGF-1. On bones and cartilage, before epiphyseal closure. GH causes liver to secrete IGF-1, which in turn causes proliferation of chondrocytes, chondrogenesis, appearance of osteoblasts, stimulation of DNA and RNA synthesis, collagen formation in cartilage, result increase in thickness of epiphyseal cartilaginous end plates, resulting in linear skeletal growth, seen maximally during puberty and causes pubertal growth spurt. Site of action of IGF-1. 44. GH action on bones B, after epiphyseal closure. No increase in bone length. Increase in bone thickness or widening through periosteal growth. Increased protein synthesis in most organs causing hyperplasia, hypertrophy, increased tissue mass and increased organ size. Hormonal effects. Relative importance of hormones in human growth at various ages. 2. Actions of GH on metabolism. Effect of GH on carbohydrate metabolism. This is a direct action of GH. Does not need IGF. GH is a diabetogenic hormone A, increases plasma glucose. GH causes hyperglycemia by increasing hepatic glucose output. Decreases peripheral utilization of glucose, anti-insulin effect, metabolic actions of GH. B. Effect of GH on protein metabolism, indirect action which requires IGF. GH is a protein anabolic hormone. It increases protein synthesis in muscle and increases lean body mass. Also increases protein synthesis in organs and increases organ size. Metabolic actions of GH. C. On fat metabolism. GH has a direct catabolic effect, mobilizes fat from adipose tissues by increasing lipolysis. Does not require IGF for this action. Increases plasma-free fatty acids, FFA, which are further used for gluconeogenesis. Ketogenic produces FFA which undergo hepatic oxidation and form ketone bodies. Growth hormone disorder. Clinical correlates of anterior pituitary dwarfism occurs due to GH deficiency, results in short stature/stunted growth. Causes: panhypopituitarism, lack of all anterior pituitary hormones, decreased GHRH, decreased IGF-1 secretion, GH receptor defect, hypophysectomy, removal of pituitary gland, a 9-year-old pituitary dwarf compared with age and sex-matched control. 52. Growth hormone excess, before puberty. Gigantism is seen due to overproduction of GH during adolescence, before puberty, before epiphyseal closure, results in excessive growth of long bones. Height, 8 feet. Clinical features: tall stature, up to 8 feet, 2.5 mts. Large hands and feet. Other associated features: bilateral gynecomastia, enlargement of breasts due to structural similarity of GH to prolactin. Coarse facial features due to increased tissue proliferation. GH excess after puberty. Acromegaly occurs due to excessive secretion of GH during adulthood, after epiphyseal closure. Causes of acromegaly are Acidophilic tumor of anterior pituitary. Hypothalamic GHRH secreting tumors. Tumor producing GHRH. Clinical features are mainly seen due to excess growth of cartilaginous and peripheral, acral, parts, and other features due to increased metabolic actions. Nose is widened and thickened. Cheekbones are obvious. Forehead bulges. Lips are thick. Facial lines are marked. Overlying skin is thickened. Mandibular overgrowth. Prognathism. Maxillary widening. Teeth separation. Other features of acromegaly. Hypertrophy of soft tissues. Heart, cardiomegaly. Liver, hepatomegaly. Kidney, renomegaly. Spleen, splenomegaly. Tongue and muscles. In 4% cases gynecomastia, breast enlargement in males, with/without lactation because of structural similarity of GH to PRL. Visual field defects if pituitary tumor compresses optic chiasm, swelling of the hands in a patient with acromegaly, which resulted in an increase in glove size and the need to remove rings. Acromegaly diagnosis: GH level, not reliable, pulsatile. IGFI is the best screening test. 75 grams OGTT tolerance test for GH suppression is the gold standard. Other: fasting and random blood sugar, HbA1c. Lipid profile. Acromegaly complications. Cardiac disease is a major cause of morbidity and mortality. 50% died before age of 50. HTN in 40%. LVH in 50%. Diastolic dysfunction as an early sign of cardiomyopathy. Acromegaly treatment: medical somatostatin analog begvisciment. Surgical resection of the tumor. ACTH disorders. ACTH disorders. CRH plus, ACTH plus, cortisol, CRH ACTH dependent Cushing's disease, plus, ACTH plus, cortisol. Autonomous ACTH secreting tumor. ACTH plus, cortisol. ACTH dependent Cushing's syndrome. ACTH independent Cushing's syndrome. Diagnosis. % of patients. ACTH dependent Cushing's syndrome. Cushing's disease. 68. Ectopic ACTH syndrome. 12. Ectopic CRH syndrome. 1. ACTH independent Cushing's syndrome. Adrenal adenoma. 10. Adrenal carcinoma. 8. Micronodular hyperplasia. 1. Macronodular hyperplasia. Pseudo-Cushing's syndrome. Major depressive disorder. Alcoholism. HPA axis, excessive cortisol. 80% HTN. Heart failure. OSA, 33% mild, 18% severe. Glucose intolerance in 60%, control of hyperglycemia. Osteoporosis with vertebral fracture, positioning of patient in OR, 50%, 20% with fracture. Thin skin. Hypoadrenalism, low ACTH and low cortisol. Nausea. Vomiting. Abdominal pain. Diarrhea. Muscle ache. Dizziness and weakness. Tiredness. Weight loss. Hypotension. Management of hypoadrenalism. Cortisol replacement, TSH producing adenoma. Very rare, less than 2.8%. Signs of hypothyroidism. High TSH, FT4, FT3. Treatment: pre-op with antithyroid meds. Pre-op, central hypothyroidism. low TSH, low free T4 and T3, central hypothyroidism, thyroxine replacement, surgical removal of pituitary adenoma if large, gonadotroph high FSH, estradiol, and low LH, high serum free alpha subunit, surgical resection if large, radiation therapy, Sheehan syndrome, panhypopituitarism. Anterior pituitary insufficiency commonly occurs in females with postpartum hemorrhage resulting in a clinical condition known as Sheehan syndrome. Anterior pituitary, which is highly vascular, gets enlarged during pregnancy. After childbirth, pituitary undergoes infarction and necrosis due to postpartum hemorrhage, giving rise to decreased levels of all the anterior pituitary hormones resulting in panhypopituitarism. Posterior pituitary hormones are not affected as ADH and oxytocin are synthesized by hypothalamic neurons. Assessment of pituitary function. Baseline, TSH, FT4, FT3, LH, FSH, prolactin, GH, IGFI, testosterone, estradiol. MRI brain. Neurothalamic evaluation of visual field. Cardiac and respiratory assessment. Anesthesiologist for airway and perioperative monitoring. Neurosurgeon. ENT for endonasal evaluation for surgical approach. Pre-op hormonal replacement. All pituitary adenomas should be covered with stress dose of HC. Posterior pituitary, neurohypophysis. 78. 79. Hormones of posterior pituitary. Oxytocin, vasopressin, antidiuretic hormone, ADH. Site of synthesis, cell bodies of magnocellular neurons in supraoptic nucleus, SON, and paraventricular nucleus PVN, of hypothalamus. PVN, predominantly oxytocin. SON predominantly vasopressin. 80. Oxytocin site of synthesis mainly PVN of hypothalamus. 1/6 SON of hypothalamus. Actions. Milk ejection. Contraction of uterus. Mechanism of action. Via G proteins. 81. Factors affecting oxytocin secretion. Factors stimulating release. Suckling. Emotions, sight, sound of baby's cry. Dilatation of cervix, parturition. Factors inhibiting release. Emotions, stress, fright. Drugs, alcohol, etc. Milk ejection reflex. Stimulus, baby suckling the nipple, skin touch receptors around nipple. Afferent, nerves for mammary glands via spinal cord, end on PVN, and SON. Center, PVN in hypothalamus. Efferent, action potentials travel down the nerve terminal to posterior pituitary, release of oxytocin into blood. Oxytocin stimulates myoepithelial cells of breast to contract. Effect, ejection of milk. Increased suckling, increased stimulation. E.g., for positive feedback. Terminated when baby stops suckling. E.g., for neuroendocrine reflex, afneural, efferent endocrine. 83. Milk ejection reflex. Parturition reflex descent of fetus, dilatation of cervix. Stimulation of stretch receptors. Increased activity of afferent nerve. Stimulation of PVN. Release of oxytocin into blood. Contraction of uterus. Expulsion of fetus. Positive feedback. 85. Vasopressin, also called antidiuretic hormone, prevents diuresis. Predominantly secreted by SON. Nonapeptide. 86. Maintenance of osmolarity and ECF volume axon DCT and CD of kidney. Vasopressin, actions. Maintenance of osmolarity and ECF volume. Axon DCT and CD of kidney. Inserts aquaporins, water channels, and increases permeability of the tubular cells to water. Increases water reabsorption. 87. But not in physiological concentrations. Vasopressin. Potent vasopressor. But not in physiological concentrations. However, during hemorrhage vasopressin levels can increase, causes vasoconstriction. 88. Factors affecting ADH release. Factors stimulating release. Increased plasma osmolarity. Hypovolemia, ECF volume. Pain, emotion, stress, exercise. Standing. Angiotensin II. Factors inhibiting release. Decreased plasma osmolarity. ECF volume. Alcohol. Diabetes insipidus, decreased ADH secretion. Characterized by polyuria, large volume of dilute urine, and polydipsia. Central DI, neurogenic. Synthesis/secretion of ADH. Inherited or required. Nephrogenic DI. Failure of receptors to respond to ADH. 90.